Welcome to Mercy Medical Center's live webinar. Today we'll be discussing ADHD, Attention Deficit Hyperactivity Disorder. Joining us are Dr. Mary Eyanson and Darcy Koehn, ARNP. After their discussion, they will take questions from our audience. To submit your questions anytime during the discussion, go to the window in the upper right-hand corner of your screen and type in your question. If you don't see the screen, click on the orange box with the white arrow, and your questions will be confidential. Well, I'm very happy to have both of you with us today, and I'm going to turn the mic over to Darcy now so we can get started.
Thanks, Lynn. So, it's the beginning of a new school year, so we thought this was a very appropriate topic to discuss. And starting out, have you had concerns that your child can't sit still, easily distracted, pretty disorganized? Well, attention deficit hyperactive disorder is one of the most common neurobehavior disorders in childhood. It's one of the 3 most common chronic health conditions of school-age children and one of the best researched disorders in medicine. And it affects 3 to 12% of school-age children. More often, 3 times more often, boys are affected than girls, but girls are more likely to have the inattentive subtype, which we're going to discuss later. And oftentimes they get missed in early elementary, or the diagnosis happens later when academic demands are more significant in elementary or in middle school. I think it's really important, we want you to know that this is not just a childhood disorder, that attention deficit hyperactive disorder persists. It persists into adolescence and adulthood in 40 to 70% of children that are diagnosed. Okay, now we're going to talk about the subtypes. Dr. Eyanson?
Thank you, Darcy. We're just going to go through symptoms of ADD and the subtypes of ADD next. Currently, there are 3 different subtypes. The first subtype is a predominantly inattentive type. The second is a predominantly hyperactive impulsive type. Third is a mixed or combined type. There are 9 symptoms of inattention and 9 symptoms of hyperactivity impulsivity. To have the inattentive type of ADD, it's required that you have, or the child has, 6 or more of these symptoms present in more than one setting. To have the hyperactive impulsive type, 6 or more of the 9 symptoms need to be present. And for children who have 6 in each category, it's considered to be the combined type. Now, the combined type is the most common type. Inattentive is next. It's fairly rare to have just a hyperactive impulsive type. And usually when you have this type, it's in preschool children. And if you follow them over the years, they usually develop the inattention and would have the combined type. Other things we look at in making a diagnosis is that the symptoms need to cause significant impairment. Many people may have these symptoms, but they don't really interfere with our life, so therefore it's not considered to be impaired. The symptoms need to be present for more than 6 months to make the diagnosis. And as I mentioned before, the symptoms need to be present in more than one setting. Also, the symptoms usually start before the age of 7. The diagnostic manual is being revised. That age is going to change to 12. Because if you look at some children, they may have some mild symptoms, but then really don't become a concern until they get closer to middle school. So people looking at this are going to change that requirement. Now we want to go through the symptoms, and I'll go through the inattended symptoms. The child will often fail to give close attention to details or makes careless mistakes in schoolwork or other activities. In school, they may not pay attention to the pluses and minus signs in their math. They may skip over words when they're reading. They may miss things because they're so careless. Often they have just trouble keeping their attention, and when they're doing schoolwork or even when they're playing with their friends, they may not pay attention to the other child, which may affect their social interactions. The kids often don't seem to listen when they're spoken to directly. Sometimes they've heard what you said, they just don't appear to be paying attention. Often kids will avoid any task that requires a lot of energy. If they see a homework project that's going to take a long time, they'll avoid it or just procrastinating getting started. Often a child does not follow through an instruction and doesn't finish homework or chores. Now, this is not because of oppositional or deliberate behavior. It's not because they don't understand it. It's often because they're not paying attention, they're distracted, they forget the assignment. Another symptom you very often see in kids is trouble organizing, and this becomes more of a concern in the older kids, especially around middle school. They're just don't remember where they put things. Sometimes it's been described as having their lockers are described as a black hole. Everything goes in, but nothing comes out. Children are very easily distracted. In school, they might be looking out the window. They may hear the little noises in the classroom, but can't pay attention to the teacher. They're often very forgetful. They forget their assignments at home. They forget to bring homework home. And they may lose things for tasks like pencils, books, toys. And as they get older, especially, they tend to lose their keys.
The hyperactive impulsive symptoms one might notice is that the child is really fidgety, wiggly in their seat, squirming. They feel a need to kind of get up from their seat, move around the classroom, leave the classroom at a time when they're expected to stay seated. Younger children especially, boy, they're active. They run, climb, when they should be able to have more quiet activities. In adolescence and adulthood, this hyperactive impulsive may be a sense of internal restlessness. They often have difficulty being quietly, playing quietly with other children. They are on the go. It seems sometimes they are just driven by a motor. They talk excessively. So you can see how those symptoms can really significantly impair their relationship with other children, with teachers, with adults. They blurt out questions even before they've been asked. They have difficulty waiting their turn. They interrupt, or they're intrusive. They're in other people's space. So, why is this so important? Well, the impact in many domains of their life is really significant. If we look just at school performance, we see a child that is not able to achieve their potential. They're not getting their work done at school. They're getting constant reminders from the teacher to pay attention and stay on task. As we talked about, they're really disorganized. Maybe be the child that has to stay in from recess to get their work done. Or they have to bring their work home from school because they didn't get it done. What about the impact that it has on the child and their family? Well, these children can be really demanding to parent. The parent feels like they're constantly repeating directions. that the child is not listening, not getting done what they need to get done. The stress level in the household for both the parent and the child is heightened. The child struggles in their relationships with teachers, with adults, with peers. And if unrecognized and untreated, the child doesn't feel very good about themselves. They don't have a sense of well-being. And as we discussed, these are really significant behavioral challenges. I like this particular slide because it shows the developmental trends over age. You can see younger children may be more hyperactive, aggressive, and low frustration tolerance. And that happens from young children, again, through adulthood. But the hyperactivity you may see more in the preschool, kindergarten, first graders. The impulsiveness, the easily distracted, inattentive, shifting activities, constantly moving from one thing to another, very easily bored, impatient, restless. And so the consideration we're giving is, what kind of impact does this have on the quality of life for the child? So that's QOL is quality of life, which is something really important that we're always looking at. Now Dr. Eyanson is going to talk about the neurobiological basis.
It has become increasingly clear that ADHD has a neurobiological basis. Many studies have been done, and even more are in the process of being done on ADHD. First of all, there's many studies looking at the neurochemistry, both in the dopamine and norepinephrine. The medications that are used affect these chemicals, and I'll show a slide a little later that shows this. A lot of the research being done is in the area of neuroimaging. There are many scans, MRIs, PET scans, and these scans show decreased activation in parts of the brain that are instrumental in helping attention and impulse control. One of the first studies that was done that was looking at the biochemistry, and I think proved to people that there is a biological basis. They did PET scans of adults who were parents of children with ADHD. These parents had symptoms but had never been treated. When they did the PET scans that look at glucose metabolism, there was less activation in the parts of the brain that showed attention and impulse control problems. And then they did the scans again, giving the adults medications like Ritalin or Dexedrine, and the tests were in a more normal level when this was done. There have been other scans that show that decreased volume in some parts of the brain. They're in the process now of collecting lots of information on functional MRIs or resting MRIs that can show a little bit of the circuitry of the brain and how the brain works. And I think over the next few years we're going to be seeing a lot of studies showing what types of kids have different problems. And right now these tests are very interesting. They're really good for research, but right now they're not yet useful for making a diagnosis. There's also several studies of genes that have been done, and I think there's not going to be just one gene that predicts ADHD, but probably multiple genes will contribute to the expression of ADHD. This slide shows the prefrontal cortex, and this is the area of the brain right behind your forehead. And this is this is where a lot of the activity in ADHD is. You can see This area affects attention, it affects behavior and judgment, it affects emotional responses. Again, in this area of the brain is also the part of the brain that's responsible for executive function. Sometimes it's referred to as a CEO of the brain. The next slide shows a picture of the connection between two nerves. The nerves are the kind of tan parts that you see, and there's a little space there where the arrow says synaptic cleft. Between the nerve cells in that synaptic cleft, there are the neurotransmitters, the dopamine, the norepinephrine. And in children with ADHD, there's less of those chemicals present. All the medications that are used work in some way to increase the amount of neurotransmitters at that level. They work in different ways, and therefore the medicines have different side effects.
So we've addressed that ADHD is neurobiological in nature. Some of the other factors that can contribute to this would be perinatal stress. So if you have a mom that was in a conflictual relationship with a lot of environmental stressors during that pregnancy, that's a risk factor. A child with a low birth weight, a child with a traumatic brain injury. I remember a little boy at the university who had fallen off the back of a motorcycle, had no problems until that traumatic brain injury, and after that there were very significant, almost uncontrollable attention deficit disorder symptoms. Maternal smoking, alcohol use, again, those are all toxins that can contribute early significant deprivation, emotional deprivation in the child's life. We know that, again, as Dr. Eyanson mentioned, that the growing evidence is that ADHD is genetic. It's inherited. If one child in the family has ADHD, there's a 25 to 35% chance that one of the siblings will be affected. If one parent has attention deficit hyperactive disorder, there's 8 times greater risk that their children will have ADHD. And again, as Dr. Eyanson said, we know that it's kind of multi-genetic in nature. There are probably 4 major genes, but another 15 that are also involved. So that's why we refer to it as a kind of multi-genetic, but fascinating research that's being done. So this just looks at the apples on your family tree. So coming to an evaluation, knowing your family history, and sharing that information with a clinician that's evaluating it can be really very helpful. Dr. Eyanson's going to talk about assessment and evaluation.
In the last several years, the Academy of Pediatrics and the American Academy of Child and Adolescent Psychiatry have both published guidelines for the assessment and management of ADHD in children. In fact, the latest one from the Academy of Pediatrics added some information about treatment in preschoolers for the first time. As we discussed before, when there are symptoms of ADHD, they occur in more than one setting. So when we're looking at a child, we like to get information from as many different settings as possible. This usually includes the parents or caregivers, and often teachers or other significant people in the child's life. We like to obtain a good history, and a lot of times we can get this through forms that we send out to parents or teachers. We also do a lot of behavior rating sheets. There are behavior rating scales that look specifically at symptoms of ADHD. There are other behavior rating scales that also look at other concerns that may be associated, like anxiety or depression. Several of the ratings give both. We often use the Vanderbilt profile that looks at the diagnostic criteria for ADD, but also gives an idea of other things that might be going on in the child's life. We obtain these ratings from the teachers. We also obtain them from the parents. And there are some ratings we can actually do with a teenager as well. We get more information from children and teenagers by using interview techniques. When we're going to see a child, we prefer to get any prior testing that's been done. If a child is getting special help at school, if he has an individualized education program, we'd like to get copies of that information as well. The history is one of the most important parts when we're looking at a child. First of all, we want to talk about the onset of the problem. How long ago did it happen? If this has been going on for a year or two, the diagnosis is a little more likely. If the symptoms just happened a month ago after a traumatic event in the child's life, you're probably talking about something else. As part of the history, we get a very complete developmental history, a history of mom's prenatal course, history of the birth of the child, early history of the child, looking at any other medical problems or developmental problems. Darcy already talked a little bit about the importance of the family history. And again, if there's a family history, diagnosis is a little more likely. It's also important to get a history of associated psychiatric disorders in the family, as these also may have a influence on the assessment. While we're going through the history, we also ask about the child's strengths. We want to know what the child is good at. Sometimes they're not good at things like school, and we want to find areas where they can be successful. The other part of the history is talking about the parents. Can the parents work together in helping their children? If parents can work together, they can be a source of strength for their child and can be a protective factor while we're working with them. It's important to realize that there's no one test that makes a diagnosis of ADHD. There's not a blood test, an EEG, an X-ray, computerized test that says, yes, this is ADD. You're talking about looking at the overall picture based on a thorough history. It's important to get a physical and neurological exam at some point to rule out any physical or neurological kind of problems that may be contributing, as well as the assessment of the behaviors. In our clinic, we also do a neurodevelopmental exam that looks at child's learning strengths and weaknesses and gives us another opportunity to observe the child's behavior. While we're doing the assessment, we look for things that might seem like they're ADD but aren't really not. Sometimes a child with mood disorders or anxiety disorders may be inattentive, but when the anxiety or mood is not there, there's not an attention problem. And this can be confusing because sometimes a child has ADD and also has an anxiety problem, so we need to try and find out what happened first. Children going through adjustment disorders, for instance, if a child's parents have become recently divorced or there's some other big stress in the family, they may start having behavior concerns that look a lot like ADHD, but they didn't have those symptoms before. So that is not likely a primary attention problem. Children with learning problems or language problems, again, may look inattentive, but when they're not stressed with a learning problem, their attention is fine. Again, that might be something that's there may not be a primary attention problem, but the attention problems because of the learning or language difficulty. After we do our evaluation, make our assessment and recommendations, sometimes we will decide that further testing is indicated. If there's a history of learning problems or significant emotional problems that are interfering, we may recommend further testing, either neuropsychological testing or a complete psychoeducational evaluation. These can be done privately, and a lot of the testing can be done through the school. If there are speech and language concerns, we would recommend evaluation. If there are concerns with fine motor or sensory difficulties, sometimes an occupational therapy consult can be very helpful. Often ADHD is not seen by itself. In fact, most children that we see at some point as we follow them may develop another disorder. Particularly in children with the hyperactivity impulsivity, it's very common to have oppositional defiant disorder. Oppositional defiant disorder is probably the most common disorder associated with ADHD. And these are children who have more deliberate oppositional behaviors, often angry, have a lot of more deliberate behavior concerns. Anxiety and depression is common. Many children have an associated learning disability. Tics are common in children with ADD. Up to 10 to 15% of children with ADHD may have a tic or develop a tic disorder at some point. On the other hand, if you have a child with a diagnosed tic disorders like Tourette's, the incidence of ADHD is much higher. In Tourette's, the incidence of them having ADHD is anywhere from 50 to 80%. In children with autism spectrum disorders, they may also have attention difficulties as well. They may be a little bit more atypical, but often treating the attention concerns may be helpful. There's also an increase in incidence of substance abuse in untreated ADHD. The studies are very interesting with this. If a young adult is treated for their ADHD, the incidence of substance use in most studies is decreased. So treating the ADHD can also sometimes be a protective factor.
So the treatment plan includes the fact that we recognize that ADHD as a chronic disorder. We want specific target outcomes to guide the management. You know, what are the chief concerns? What are the top priorities? What do we really want to work on first? Again, going from a strength-based perspective, what is the child good at? And how can we maximize those strengths and encourage the development of those strengths? And as Dr. Eyanson talked about, looking at, is there something else that's going on? We really do need to look at how most effectively to treat the oppositional defiant disorder or the child that's anxious or the child that's depressed. So that's part of that overall plan. We talk about a multimodal treatment that includes a variety of things. And number one is parent education. Learn as much as you possibly can. We're going to talk a little bit about this later, but CHAD, Children and Adults with Attention Deficit Disorder, is just the pivotal support group. We have it's a national voluntary group. We have a local chapter. There's publications. There's national conferences, and just learn as much as you can about ADHD. Learning behavioral interventions, learning how to give effective directions to your child. Medication certainly can be a very important part of it. It's important that if child is given medication, that there's regular monitoring by a qualified professional. Are we giving the right medication in the right dose at the right time? Is it doing what we want it to do? So when we see children on an ongoing basis, we follow them every 1 to 2 to 3 months in early childhood and earlier in elementary and middle school to make sure that we're getting information from the parents, from the child, and the teachers on what we're doing is what we're doing working. It also may mean that this child needs some accommodations in the classroom. They may need something called a 504 plan that says, hey, your ADHD is a disability, and you would benefit from tests in a quiet place, time and a half for taking tests, maybe shortened assignments, fewer homework problems. Also part of the multimodal treatment is counseling, helping the child to understand themselves, helping the parents to understand it, helping the parents to learn some effective strategies, and knowing, again, what's out there for resources. So who's on your team? Well, the parent's the most important part of the team. Your healthcare provider, teachers, counselors, all of those are, it takes a village to raise a child, and that's all part of the team. So, talking about medication, Dr. Eyanson's going to talk about this a little more in more detail, but there are both stimulant and non-stimulant types of medications. And using medications, you can increase the child's concentration. They're more persistent, less impulsive. Their work production is better. They have better emotional control. They can be even less aggressive and defiant. They are more compliant, better able to follow rules, and their working memory and their ability to kind of talk themselves through a situation is better. So Dr. Eyanson is going to talk more about medication.
First of all, I want to talk a little about the stimulant medications. The stimulants are the medications that have been around the longest, some of them up to 40 to 50 years at this point. And they're also the medications that are the most effective. If you use more than one medication, if one doesn't work, if you try another one, the effectiveness rate is somewhere between 80 and 90%. There are 3 different types of stimulants: Ritalin, Adderall, and Dexedrine. They all now come in long-acting forms. All the long-acting forms listed here have been approved by the FDA for treatment in use in ADHD. FDA treatment means they've been through rigorous studies and work effectively and don't have significant side effects. All of these medications come in short-acting, which are like 4 hours, intermediate acting, and long-acting. And the long-acting can be anywhere from 8 to 10 hours and even longer. There's the Daytrana patch will last 3 hours after you take it off, so you can really tailor how long it will work. So usually with these medicines you can get all-day coverage. Just let me go through a little bit of side effects. Side effects are similar for all three medications, but one may have more than one in a certain child, and it's hard to predict which child will react to one or the other. The common side effects are, you can get a little bit of irritability, tummy ache, getting used to it. Most common side effect is some appetite decrease when it's in effect, so we recommend parents give the medication with a good breakfast, preferably with protein, because protein can also help concentration. Difficulty with sleep is also very common, sometimes even before starting stimulant medication. So we sometimes have to adjust the medication because of the sleep difficulties, try something else, or sometimes try something for sleep. If a child's ever too quiet, zombie-like change in personality, it's the wrong medicine or the wrong dose, so we need to make an adjustment. If a child develops tics on medication, we would monitor that carefully. Sometimes tics will go lessen with time. On other times, the tics continue and we may need to try a different medication. There is a warning on the stimulant medicines. If you have a pre-existing heart problem, you need to be much more cautious. There are two types of non-stimulant medications out now, and these have advantages in some cases. The first one that was on the market was Strattera, which works on the norepinephrine. It has a 24-hour effect. It's given once a day, either in the morning or afternoon, and it can last up to the full day. It works more slowly than the stimulants. The stimulants, you sometimes see an improvement in the first dose that's given. With Strattera, it takes 3 or 4 weeks to build up the dose. Side effects of Strattera are primarily from stomach ache, especially if it's given on an empty stomach. It can be a gastric irritant. Kids can get sleepy on Strattera. Sometimes they get used to it. Sometimes it has to be given later in the day. You can get occasional rashes and sometimes dizziness. The other type of medications are the Intuniv and Capve, or long-acting form of Tenex or clonidine. And these work on the neurotransmitters in a different way. They both started as blood pressure medicines. They often have more of a calming effect than some of the other medications, often useful in treatment of tics. So if a child has a tic disorder, they may be the first-line treatment. They can be helpful with oppositional behaviors and also helpful with kids who are aggressive. Side effects mostly are some sleepiness, may have you can get sleepiness with the medications. So the last two medications are particularly useful if you have a tic disorder. We're getting our slides confused, sorry. Just one addition when talking about the specific medications. There have been some studies recently that showed combination treatment being effective, and the combination has been particularly effective in some children who have concerns with the executive functioning. Now, when we start a medication trial, we like to educate the parent about the benefits and side effects of medication. We want to make sure that they realize that ADHD is a chronic condition that will require ongoing treatment. When we first start medication, we will get baseline ratings from parents and teachers, and then during the first month of treatment, get follow-up ratings that looks at both effects and the side effects of the medication. So when we see the child back, we can decide if a change in treatment needs to be made. If one stimulant has not been effective, we'll often try a second stimulant medication, depending on what the side effects were. If indicated, we may try a non-stimulant. And again, those would be in cases where there were tics or if the stimulant was not tolerated well. And as Darcy talked a little bit about, we do ongoing monitoring to ensure that we're using the optimal dose of medication, monitor height, weight, and vital signs, and do ongoing follow-up with behavior rating sheets.
One of the things that we also, I think, is very important to look at is that children with attention deficit disorder have some significant deficits in executive functioning. When I show this to parents, I just get this aha moment. I think some of the information came from a book that was called Late, Lost, and Unprepared, and parents have thought, oh man, they wrote that book just about my child. So the child would have problems with planning and organization of their materials. Their working memory, just being able to keep things up there, remembering that algebra equation or remembering that the particular phrase and recall is difficult. Their alertness, activation, and effort are impaired. That ability to shift from one thing to another. That ability to kind of inhibit and stop and think before you say something or do something. Ability to kind of monitor yourself and emotional control are all elements of executive functioning. And over the last couple decades, we've really made great strides in understanding the brain and understanding the role of the prefrontal cortex. Executive functioning is important for any of our goal-directed activities. So we see sometimes as kids get in middle school where the demands of keeping track of things, multiple teachers, multiple assignments is really challenging, and they kind of hit a brick wall. So what happens if ADHD is not diagnosed or is undertreated or untreated? Well, these children and adults are much more likely to use the healthcare system. There's more accidents, more bike accidents, more visits to the emergency room. They're 2 to 4 times more likely to be in motor vehicle crashes. As a child reaches adolescence, we talk about the importance of treating children that are driving, that they will have fewer accidents. The accidents they have will be less severe. They'll have better braking time, better reaction time. What about school and occupation? Well, untreated ADHD, they're 46% more likely to be expelled, 35% more likely to drop out. They're going to have lower occupational status in life. In society, we talked about substance use disorders of untreated or undertreated. They're 2 times greater likely to have substance use disorders. They're the kids that have earlier to try out things, and they're less likely to be successful in quitting in adulthood. The ADHD in the child, parents are more likely to get a divorce or separation. There's more fighting in the family. In the employer situation, for the parent, they're more likely to have absenteeism, get called to go to school, and just have more difficulty parenting their child, which has implications for their employer. So that's why we talk about how important it is to have this evaluated and treated effectively. So what do you do if you think, gee, maybe my child, maybe I've been hearing this from parents or from their teachers. Has this been on the report cards or in parent-teacher conferences? I've been hearing some of the things we've talked about today. Well, take a look at your child doing their homework. Are they easily distracted? Really have a hard time kind of staying with it? Have difficulty kind of remembering to get any chores done? Their peer relationships are not what you'd hoped. Talk with the child's teacher. Talk about with your family doctor. So in summary and conclusion, we know that attention deficit hyperactive disorder is a very common childhood disorder. The symptoms can cause really significant impairment, but treatment can be highly effective. There are some really good resources that are listed. I've talked about CHAD earlier, Attitude Magazine. Both of these, number 2 and 3, have great publications, great newsletters, great emails. The National Institute of Mental Health and the National Alliance for the Mentally Ill are also excellent websites that do a lot of good work in mental health disorders in children. So again, just in conclusion, just remember that parents are their first and most important teacher, and that parenting is a great art as well as a tremendous responsibility. So we look forward to your questions.
Well, thank you both, and we do want to get right to your questions. And to remind you, your questions can be submitted by the box in the upper right-hand corner of your screen, and we will get started with our first question here. First question, if I put my child on a stimulant medication, will he become addicted? Which one? Who wants to take this question? Dr. Eyanson?
It's been shown in children with ADHD on stimulant medication that the medication in the doses that it's used for ADHD does not cause addiction. And in fact, I think I mentioned earlier in the talk that if a child has ADHD, they do have an increased risk of substance use, but if they're actually treated for the ADD, that risk may decrease.
We seem to have some technical difficulties, have lost our screen with the printed text on it, but we're going to assume everyone is still able to hear us out there and are able to get your questions submitted to us. Not sure what we have going on here. We do have another question. One question just came up. In fact, is there any way to view the webinar at a later date? And yes, the answer is yes. A tape of this program is going to be available at www.mercycare.org/live in a day or so. So you can check back there for information about this you'll be able to view this entire webinar, including the questions. Question just came in. You've talked only about children. What about diagnosis in adults? Who would like to take this question?
That's a really good question. I think oftentimes we see parents who bring their children in, and you'll have a parent that will sit back and say, I had those same problems when I was a child. And then they begin to have a greater kind of understanding and recognition. So I think it is really important that you recognize that maybe that's what's going on with me. Now, Mercy has a really excellent psychiatric clinic where there's a psychiatrist and 3 nurse practitioners who are very adept and skilled and competent and psychologists in dealing with and identifying and evaluating attention deficit disorder in adults. So I would really highly recommend that parents, that if adults have some concerns that this may be me, because it could be something else, that they have it evaluated and treated.
Next question, if I ask my school for a 504 plan, will they know what I'm asking for?
The schools are aware of 504 plans. You can ask for Grant with AEA to be involved in setting that up as well. At least there used to be a coordinator through Grant with AAA to help with 504 plans. The other thing you can do is look on the CHAD website and look for 504 plans, and they have paperwork that is specifically designed for helping you learn to set up a 504 plan. If you have other questions, you can call our clinic. We have some information.
Darcy, did you have something you wanted to add?
I know the Cedar Rapids Schools has a publication that is all about 504 plans that you should be able to ask the principal, the counselor, the teacher to get access if you're in the Cedar Rapids Schools.
Next question, are there any ways to treat ADHD with altered diet or environment? And Darcy, can take this one?
Certainly we talked about some environmental modifications. What are some things that can be done in the classroom to help? Maybe the child needs more preferential seating. They need assignments both orally and in writing. So there are a lot of ways that teachers can accommodate and look at the child's learning environment. In terms of diet, there was a lot of information out there looking at diet. The sound research studies have not shown that to be have any significant impact. I wish there was. There is some increasing support that the use of omega-3 fatty acids, so taking an oral omega-3 that many adults do, can help the neurobiology of the brain. So I think that's an important consideration. You want to find, again, a pharmacist that's knowledgeable and some assistance in getting your child on the right dose of omega-3s.
Yeah, again, the omega-3s may have some additive effects to the stimulant medications. Their effect size is not as high as the stimulant medications themselves.
Will stimulant treatment make my child shorter? Who would like to take this question?
Stimulant medications decrease appetite, and if you stay on high doses of stimulant every day of the week, you may have some decrease in overall height and weight, which usually when the medication is stopped, you get rebound growth. So it's important to monitor and use the medication at the lowest dose. The other complicating thing is this: if you look at children with ADHD and look at their height, even untreated, there's some decrease in height compared to peers. So there may be more than one reason for sometimes having decreased height.
Next question. I'm worried my child is ADHD because he has a hard time sitting still and being quiet and is always running on high speed. His dad had ADHD as a child. His teacher is suggesting he might be ADHD. At what point do I become concerned? He's only 5. Which one? Dr. Eyanson? Okay.
I think anytime the symptoms are enough, they're causing interference with family life, if they're causing interference for him at school, if they're causing concerns with his self-esteem, you should be concerned. You may want to start with talking to your teacher more about what exactly that she's seeing, and talk to the family doctor. who may also give you advice or possibly make a referral. You don't necessarily start with medication, but you may want to work with a counselor who could help you with some behavior management techniques in helping your child.
Good question, good answer. They're both. I'm concerned that my child won't learn to control himself but will become dependent on the medication. Is there any basis to this?
You know, I think sometimes people have fears about that, but effectively treating attention deficit disorder, the child is going to have better impulse control. They're going to be better able to follow directions. So I think that's less likely to be a concern. We have another question.
How has the stigma of diagnoses changed? Years ago, it was not a good thing to be labeled as ADHD and affected the child throughout his school years, even if he was treated and improved. How is the labeling different now? I'm hesitant to proceed because I don't want it to affect my child adversely, even though he might need the help. Tough question there. Who wants to take this one?
Well, you know, I hope that in the last few years we have opened up the area of children's mental health, and we've maybe acknowledged and talked about difficulties that children have. And certainly ADHD has been talked about, you know, for a long time. I hope that we're more open, but I know that that's always not necessarily the case. But remember, the impact of not evaluating it and not treating it may have really significant concerns for the child. Their academic achievement is not going to be as great. Their peer relationships are going to struggle. Their parent-child relationships are not going to be as strong. So I think it's important to at least have it evaluated so that you know if that's what was going on. In terms of the stigma, when you take a look at some groups like, you know, CHAD and their website and an Attitude magazine, they've done a beautiful job, I think, of educating parents and community about the disorder, and hopefully we're learning more and the stigma is less.
You might also add that if a child does have a diagnosis of ADHD, they're more likely to get help in school, and they can get help all the way through college years if needed. So if the child is struggling, it is important to get a diagnosis.
Very good point. Related to this a bit, does insurance cover treatment for ADHD, and is a referral needed to be seen in your office?
If you're interested in evaluation, you could check with our secretaries, and they could determine if your particular insurance would cover. For the most part, we are fairly well covered by different insurances.
And is a referral needed?
We do ask for a family doctor referral for the initial evaluation.
And again, because we've lost our screen, at least we're not seeing it from my office, any questions you can have should be addressed on their telephone number is 319-398-6585. 319-398-6585. Another question. I thought tics were caused by anxiety. Can you give me more information about tics and the relationship to ADHD? Darcy can take this one.
You know, when children have tic disorder and they're more anxious, it's more likely to be prevalent. But no, it's not. It's a different thing than anxiety. Anxiety is going to make it worse. But Dr. Eyanson talked about how prevalent either motor tics or vocal tics are in the school-age child. So it's a relatively, you know, common phenomenon.
I've heard children may be more likely to develop drug problems later in life due to taking medication early for ADHD. Is there anything to this?
I hope that we've addressed that, because one of the things that we wanted to talk about was that we want to see that child adequately evaluated and treated. Then they're much more likely to have good school success, be less impulsive, and just have much better self-regulation, and much more likely to have. And again, the studies have shown that treatment for attention deficit disorder can be a protective factor against substance abuse.
And normally I would show our slide with our list of resources again, and I know we went through those rather quickly before we lost the screen, but Dr. Eyanson or Darcy, do you want to share other places they can get information, resources, and to learn more about this?
You can contact CHAD, the Parent Support Group. Either the national one, online one is really good. Locally, you can contact the Parent Educator Partnership at Grantwood AEA. They have amazing resources available about not just ADHD, but learning problems and other disorders. And they have people trained out there who can answer your questions.
The other thing I wanted to say about the CHAD is that, again, CHAD has local chapters, and we have Kathy Harriet on board as the local CHAD president in the Cedar Rapids area. Iowa City has a chapter, and the one in Cedar Rapids meets here at Mercy Medical Center on a monthly basis during the calendar year, and really works at addressing the concerns that parents have. And we encourage anybody that's interested to learn more about it. When you look at the CHAD website, you can get the contact on the local chapter also.
Again, I want to repeat that a tape of this program will be available at www.mercycare.org/live in a day or so. And then you can always check back at this website for information about future webinars and listen to past webinars. Our next webinar topic is Breast Cancer Updates with Dr. Jasmine Nabi. The webinar will be Thursday, October 11th from noon to 1, and she will take your questions live after her discussion. Now, I believe we have covered all the questions that were submitted to us. Dr. Eyanson, Darcy, do you have anything else more to add? Okay, well, thank you very much. Again, if you have additional questions or concerns, they can be reached at 319-398-6585. And thank you all for joining us today.